Well, thanks, Warren. Thank you so much. Thank you, everyone, for having me here. I have to say, I've never seen a child with this condition, but then again, it's rare. And I have worked with many children with behavior problems that are associated with severe neurologic injuries and impairments. So I do think I have something to add to the conversation, but mostly as I was trying to learn up about this and went all over YouTube and clicking on everything about your kids, I was like, these are amazing parents and incredible kids. And then I'm walking the hallway and I'm seeing these beautiful children. So I just want to say that I'm probably the learner here. And anything I can add to the conversation, I'm glad to do. And again, just grateful to be in such a group that's such beautiful people. So thank you for inviting me here. Right, that's me, Joe Ricciardi, and I'm a clinical psychologist. I'm also this BCBA. If you've dealt with BCBAs in your school, I might apologize a little bit. They can be a little bit narrow in their thinking. I don't think of myself as that. I'm a clinical psychologist who also does the behavior analysis. I was a president of the one of the largest groups of behavior analysts for 7 years. So when I say I'm a little offended by some of their behavior, I can say that because I was their president for a while. I'm on the journals, I publish in it. So think of this as what I'm offering you as maybe what a behavioral approach towards behavior challenges could look like if someone were to think broadly beyond one dimension and think more of like what it's like for kids and families. That's how I like to approach it because I was trained as a clinical psychologist. And then also, dealing with kids with brain injury, I know it's not so simple. It's very complicated. I only have 60 minutes to go through all the complexity. So going to do our best here, right? I wanted to share with you how we ought to understand these problems, some behavioral interventions that we use, the principles that we employ, and I'm going to use lots of case examples with some data. And the issue there is, can you see in that principles of behavior that work for you in your home, right? And there's one book I'm going to give you a recommendation to. I could say that all these cases I'm going to do in some way, you could look towards this parent-friendly book for getting ideas for what to do at home. And then really, I want you to pick up on a philosophy of care, and then maybe we have some time for question and answer as well. So this is the most important. This is the core of the whole thing. No blame. That's the first part. And we got to get every clinician to work this way. We got everyone to think of themselves, if you're dealing with a child with behavior problems, as no blame. You are not the cause of the problems. There's no possible way. No possible way. We got to get that one out of your head because when it's in your head, it's hard to be effective, So if you've got that in your head, we got to get some counseling, or you got to get a friend, or you got to have a network like this. Some of the best advice for parents when I work with kids with autism, is like, what was the best advice you got? And I'm thinking, well, this behaviorist told me the following. And they said, a parent told me it's going to get better. And I was like, just keep trying. The parent told me. So really, there's lots of ways to get this out of your head, but you are not the cause of the problems. And your child is not to be blamed. And if you're working with caregivers that look like they want to blame your kid, then they've got a misunderstanding of the whole thing. One of the reasons why kids with brain injury-related behavior problems seem like they ought to be blamed is because of splinter skills. They're so communicative and talkative and so smart, and yet they had that meltdown when you told them no. They're manipulating you. That's not what's going on. Social, emotional development could be down here because of brain injuries, and then their other communication could be up here. So you see these splinter skills and you assume volition the whole time. So that's one of the problems. And then the school may not know what's going on, but they're trying. In brain injury, most of the schools don't have a good background in how to understand neurobehavioral problems. And so I always tell the families that I'm consulting with that we're going to try to work out a good relationship with the teachers, and we're going to try to work out a good understanding of this problem that everyone can agree with. And when we do that, we're starting on the same page. These are complex problems. Three things that make them complicated is the neurology, of course, the injuries or profound dysfunction that's happened over time because of blood flow issues and whatnot. Learning processes are at play. So the brain injury, the brain problems are an instigating cause. They make contact with the environment, and then bad habits get learned over time. That's how we frame it. Notice I'm saying bad habits, right? I'm not saying the child's bad. Bad habits. These are habits, and that's good to know. I don't want to say out loud what they are, but I have my bad habits, okay? And I've learned them over time. And now they're me. And it's like, how do I get out of this? What if it were so easy you could just say, all right, start going to the gym, stop eating pizza. I'll just do it tomorrow. Well, that's not going to work. But if I set some goals around that and had some legitimate strategies, maybe 6 months from now, I could look back and go, wow, I lost 12 pounds and I've my cholesterol is good. But learning takes time. And so that's the other part of it. And then finally, you have a developing child. So the target is moving all the time. And that's another problem with these behavioral challenges. So I'll use the term neurobehavioral disorders. The school that I work at, I work with the May Institute. We have about 6 schools, kids with autism, except for one, which is for kids with brain injuries. And I'm the consulting psychologist there. And I also train interns, doctoral interns and postdoctoral fellows on how to work with children with these challenges. And we use the term neurobehavioral disorder. It means that these are chronic, prolonged, long-lasting problems that have to do with an injury to the brain. That's almost the beginning of it, the incidental cause. And then the challenging behaviors interfere. They become a disorder in that they keep the child away from the best learning they could do. They might impair with social development, and they adversely affect relationships. They can be small things like behavioral outbursts that are noisy and everything. They can be refusal to engage in school, won't go to school, and then they can be very severe aggression and property destruction. That's what we see at our school. And I wanted to share that with you because if we can unravel some of the problems of this high intensity, the same principles can be used with lower intensity concerns. We look forward at our school to the lower intensity concerns because we are so good at moving the higher intensity concerns towards improvement. But when these problems persist, then they become lasting challenges to relationships and school placements and learning. Does that sound about right? Okay. So now in MSMDS, the neurological complications that could be potential contributing factors are listed up here. You're familiar with a lot of them, but when you have white matter changes, injuries, or white matter is needed, and I'll go into this just a little bit. You're all familiar, it needs to connect areas of the brain. There's no one place in the brain where everything is centered. They communicate with one another, they use the white matter. So if there's any disruption in white matter, we're not going to get the full performance that we should. And that's going to be our splinter skills. I can't communicate well, but I have all of this motor. I don't have the motor, but I have this, and I want something, and I can't use my limbs as the way I want to. Frustration builds up. I don't have the social emotional development because of a particular white matter location of injury or a cortical injury, and I have outbursts. So there's also the blood flow abnormalities that can hypoperfuse. You're familiar with that. So that would be like parts of my brain aren't getting all the blood oxygen that they need, and that can cause injuries or poor performance. And then there are actual acquired brain injuries. So the brain was injured through bleeds. And then the secondary factors are huge as well. And this is going to be where children who are dealing with the chronic stress of prolonged hospitalization and medical procedures and missing things, missing social opportunities, and also the stress of it. Those are all these factors that have nothing to do with your child or you that are huge contributors to the problem that I'm going to guess that teachers need to be educated on if they're going to be able to be compassionate and be understanding about what you're doing and what your child is going through. So this is some good information. This is the human brain growth chart. So this is 100,000 or so MRIs across the lifespan, and they're all sort of pulled together. They meet a particular standard of quality, and from this we gather what the brain is supposed to be looking like from conception all the way to birth, and just tracing through the light orange there. That's the white matter changing. So if an injury happens somewhere along that trajectory, right? We saw Dr. Yale talk about what happens with a motor skill injury, right? And then there's a drop and a decline, and my motor performance may not ever get to where it was supposed to be. That was one of her slides. So the same thing could be said about the white matter development. If I had a white matter injury at a particular time, then the next functions that are supposed to happen when that trajectory goes where it's supposed to be would be impaired. And the same thing you see on the top there, the cortical thickness, that's all intrauterine, but there's also cortical changes that are happening after birth. And the cortex, the outer surface of the brain, is going to be places where functions are located, and our white matter connects them all together. So the point here is that look at all the brain development that's going on way into the 20s or so. And if there's an injury that happens somewhere at what age, it's going to affect functions later to come. Supposed to produce something with all these distributed functions. And then in order to do something down at the bottom there, this would be like a child sitting in a classroom and hearing the teacher talk and seeing words and asking to respond, and look at all the different areas of the brain that have to be involved. And if there's a cortex that's injured, then that function is not going to be happening as it should. If there's a white matter tract that's injured, then we're not going to be able to communicate. But it just goes to show you the complexity of a simple thing. Like, I'm sitting in class, I'm hearing the teacher talk, and I'm supposed to respond quickly like all the other kids. And if one of those things is disrupted, then I'm not going to be doing as the others are. And this creates an opportunity for challenging behavior. These are 5 areas of cognition. You'll see, I think in your kids, probably people have done some neuropsych testing and they've pointed out processing speed problems. But these are the areas that would be affected by any of those injuries that we just mentioned. So here's our neurobehavioral formulation. First, the brain is in development and it progresses from conception all the way to adulthood. And any injury, the timing of it is going to be affect functions yet to develop. Okay, that's the first part of it. So, and it can affect the development of communication, emotional self-regulation, social cognition, executive function. Whenever we have a kid in our school that has a neurobehavioral disorder, something here, or more than one, is affected. Something is affected because these are the things that help us be able to function well in life. And this is the thing that parents do when they're bringing up kids, right? Communicate needs and wants. So when we're raising our kids, we say things like, when they have their, use your words. I'm not going to listen to you. You need to slow down and tell me. So we teach the kids to use words as an alternative to problem behavior. If they have communication impairments due to a brain injury, then they're at deficit for learning that critical skill that prevents problem behavior. Manage your strong emotions. You need to calm down first. Take a few deep breaths. We say it to our kids all the time. And then anticipate the effect of their behavior on others. So, well, how would you feel if someone did that to you? We're teaching them to build that social cognition right up here. I think it's the, let's say, dorsal lateral right prefrontal cortex. Anyway, we're trying to develop that area of the brain naturally. When my boy was about 2 years old or so, I told him no or something, and he went up to me and he slapped me. So it didn't really hurt, but I went, "Ow, Michael, that hurt." And he went, "Dad!" He burst into tears and he grabbed hold of me. So what's going on there is his social cognition is not developed strong enough to inhibit, right, his aggression. No, you can't have an aggressive response. And then he says, "No, I'm sorry. I wish I hadn't done that." And he cries and he grabs a hold of me. That's sort of on the cusp of how social cognition can help inhibit. So if I have a brain injury that affects my social cognition development, I'm also at deficit for what naturally would be inhibiting a problem behavior. I'll share with you a boy that one of our cases, and he loves his clinician. She's my student. She's an intern in clinical psychology, and she's blocking and managing him. And he goes, "Can you tie my shoe?" And she's like, "This is good. He's coming out of it." And then he double hair pulls her and drops to the ground. And then she gets up and does that. And then he drops to the ground and goes, "I'm sorry." And then she goes, "It's okay." And then he swats and then she steps back. And then he's like, "I'm a bad one. I don't want to be a bad boy." And she's like, "It's okay." This is a boy who's in the middle of, I want to do better and I'm struggling. And it's the way my brain is not working, right? And this is why this formulation here is why my intern can calmly wait and respond to when he's on track, and then back off and wait and respond when he's on track. And what she's doing there is she's saying, the boy I'm treating is this kid who wants to do better. That's her attitude. And that's why she can be so effective with him. She really believes in him. There's no blame going on. And then finally, we also ask our kids to do executive functions. We say, stay on track, come on, get these things done, and then you can do the things you want to do. And if parts of the executive function is so distributed, areas of the brain that are impacted, I'll have a child that has real problems with getting stuff done. And all of these things are important because they help us perform well in life and they minimize frustration. I like this slide so much, I did it twice. So now here's what happens. These problems become emergent, all right, because the challenges at home, the challenges with friends, or the challenges at school keep getting harder. And eventually I reached the point where I can't compete anymore and it's frustrating. And challenging behavior emerges for the child as a solution to the problems that I'm having. They're not volitional. Then I think if I start hitting people, I'll get what I want. That's not what happens. I hit something and then accidentally, okay, let's take a break now. And a child with very poor problem solving, very poor self-control can learn not by volition, but can be shaped towards more and more aggression as a way to escape and avoid the things I don't want to do. I heard Dr. Yale this morning talk about her daughter saying, well, I'm just not going to school today. And she said, okay, well, it's going to be one of those days. I'm sure nobody's benign about it. But that's an attitude of someone who says, good days and bad days. We're not going to take it personally. We're not going to get into struggles, right? And that's how you get out of some of these problems. Dr. Yale's treating it as this is something to be learned next time. How do we do better the next morning? And they'll figure it out that way. So when developmental expectations increase, like going to school when you're a teen and you're not quite feeling like it, you're not going to do as well, but over time you can learn them, tolerate those things. And then finally, what happens when the developmental expectations are so high, the environment is still pressuring me, it leads to frustration, distress, bad learning, and bad habits. That's our whole neurobehavioral model. So it's this interaction between my brain, okay, the challenges I have with doing the things that kids need to do, and the environment, which has accidentally reinforced behavior over time. And we keep using the word accidentally. We call it adventitious reinforcement. So this is called the circumstances view of problem behavior. That challenging behavior is learned over time through this accidental process of reinforcement. No one ever wanted to create behavior problems. And here they are. Here we are with them. What happened? Okay. The circumstances view of problem behavior is very, very valuable because when it's understood by caregivers and staff, it's very liberating. It wells up compassion when people understand nobody's at fault here. Nobody's to blame. The child's not doing this on purpose. If they can frame it that way, they become much more effective caregivers. I see this in our residential staff. I've seen it on inpatient unit staff in a hospital. I see it in teachers all the time. Here's like a metaphor for it, right? You've had this experience. You're in traffic and you're narrowing down to take this left at the light, and the car ahead of you lets the light go green and then waits there, and then all of a sudden it's red again, and you're like, well, okay, just go, and cars are beeping and they're pulling around, and now it's your turn, the light goes green again, you're like, come on, what's going on? And the person's on their cell phone. They get out of your car, you go over there to knock on the window to say, come on, right? And then you realize the mom's on the phone with 911. She's dropping the phone to give CPR to her baby. She's back. And all of a sudden you're like, I'll call 911. You do the CPR, right? It's just a story. But what it means is when you understand the circumstances, it can sort of evoke a helper response. I want to help now, right? You went from angry, move your car, to I'll call 911. You do the CPR. You became a helper like that when you understand the deeper circumstances. So that's why we work so hard in our neurobehavioral cases to unravel how is the neurology instigating the behavior, what's been learned and has been functional for the child over time, and then the natural help is how do I teach new skills? How do I teach new things that this child could do to solve their problems? So that's the whole formulation there. The fault is not on character or weakness, neither the child nor the family. And it's a series of unfortunate things. This is my own idea. This is Dr. Pat Fryman. He has a TED Talk on the topic, but he's also published it. He calls it, there's no such thing as a bad boy. He takes that concept from Father Flanagan of Boys Town, famous quote from the 30s or so, who said, Father Flanagan took some of the roughest little kids running around Omaha, Nebraska. They just let these kids who were homeless and run wild. They formed little gangs. They stole. They did thievery. He said, round them up. I want to create a home for them. I don't think they're bad kids. They just had bad circumstances in life, bad environment, bad modeling, bad teaching. And the Boys Town remains today one of the highest success rate diversion programs for youth who are having legal challenges. So they engage in multi-social behavior. It's one of the most successful programs, and this is the core philosophy. And that's what we're sharing here. So we move with the circumstances approach to not a search for blame, but a search for solutions. There's something in the environment that if we can improve it, there's something to be taught. If we could teach it, there's some new learning. If we could add rewards, then we'll get more effective children. And this is called being hard on the problem, but easy on the child. hard on the problem, easy on the child. And these are the three core principles then. Whenever we want to come up with a behavior plan, whether it's in your home, whether it's a plan in a classroom, whether it's a plan in one of our therapeutic residences, what can we do to prevent the problem? What could we teach that's new? And what could we reward? We create a very rewarding environment, and we teach new skills, and we prevent problems where we can. So modify the environment so the things that trigger the problem are less likely to be there. So the second strategy is new skills, and I'll get into some examples, and then add rewards. Think about this environment for a child who's been either perniciously blamed, or they just felt themselves to be that blame and ashamed of their problem. And that little boy was melting down with my intern, and he said, "I'm such a bad boy. I want to stop this. I want to be good." Where did he learn that? You know, we don't talk like that to him. So the world either told him stop being bad, or he saw it on TV or whatever, but he's got this the weight of the world on his shoulders. I'm bad, you know, and we have this therapeutic approach where we prompt much better. There's amazing staff who get their hair pulled, the kids back on instruction, and said, "How you doing today, Tommy? You're looking like you're back on track." Like, where did that soul come from that could go over to a child and tell them, "Good job, you're back on track now"? But that's the therapeutic environment that a child with a neurobehavioral problem has to have. They know that they're not meeting expectations and they want to. I've had many kids tell me that. I once showed a little girl her own little graph. It's a girl with moderate intellectual disability. And I said, actually, you know, sometimes things get hard for you and you feel like biting yourself, or sometimes you get so angry and frustrated you want to hit a teacher. And she goes, "Yeah." And I said, "Look." And then she saw the graph, moderate intellectual disability, going down. And she said, "Good girl, Ashley, good girl." She was proud of herself, knowing that she was gaining in self-control. So we also have to look at our kids thinking a therapeutic approach to their challenging behavior, thinking of them as people who want to improve, and then give them the right strategies in the right time. So that's our three core principles. There's a lot of research that supports this in people with brain injury. So there's the soccer, that's like a lit review, and then an updated lit review, and another 7 years later, and then the 2023, another. So all of these things are pulling together the idea that these are the sort of strategies that significant research supports for making behavior change. I'll walk you through some of these, but basically the top here is going to be, how do you prevent? So with kids and adults, I've worked with adults with brain injury, with these neurobehavioral challenges, mapping out a structure for their day, a simple list of what I'm going to do and work on is almost universally the beginning of improvement. Anything you can do to add structure. Well, he does have a to-do list, but he doesn't do it. Do we have pictures on the to-do list? Well, he does have a to-do list and he has pictures on it, but doesn't do it. Can we sit there and accompany him and prompt him and praise him and add a tangible reward at the end of doing one of these things? All of these things are structures that help someone do well. So a well-understood structured daily routine, choice and control over activities. We do it with a lot of kids. We have them look out at their work, at their desk. Which one do you want to do? I'm not doing math today. And which one do you want to do? I'm going to do reading. Okay, put it aside. 9 times out of 10, after they've got the momentum going, they pick up the math. All right, I'll get it done. But if we didn't have choice and control going on there, and why does that child need that? Their neurobehavioral. Everything's on the weight of the world on me right now. It's frustrating. I only know what I don't like right now. Get that away from me. I'll do this. And we don't say, stop being spiteful, stop being disrespectful. You do what I say. We just go, okay, all right, so let's start with the reading. And in time, we get everything done. So having choice and control. Sometimes we take task expectations, like the math is really hard for me, so I'm not going to do it. And we say, well, let's trade problems. Give me the hardest one. I'll do that one first. All right, pick the easiest one for you. And then they go back and forth a couple of times. And the next day, maybe they're doing more on their own, or maybe after a week or so, they're doing more on their own. But what we're seeing is the end goal is ultimately my frustrations are something that I can have and still do my math worksheet. So I modify the demands to make it less demanding and ease you along. We give lots of breaks for highly preferred activities. Of course, it's all technology. So we have a little technology shelf. Technology goes in the closet. Everybody puts it there. When you're done with your work, you pull out your tech, you get it for a certain time, you put a timer on. And the timer is bing, the structure of tech time's over. Let's go over here. And sometimes there are meltdowns when tech time's over. But over time, kids can learn that, okay, I'll get it back as soon as I get this done. And it's that structure over time that helps and the interspersal of their favorite things. So those are just some ideas that that we draw from the literature. The next one is, can we teach and reinforce? So prevent, teach, reinforce. We teach a lot of self-management skills, kids who learn to deep breathe and cope and things like that. We never start off with kids having a meltdown, use your coping skill. We never do that. We take them aside. We have a few practice sessions. Mom's going to do the coping skill, or teacher's going to do the coping skill, and now you try it. I don't want to do it. Let's bring over your favorite teacher. Who's that? I think that's indulging, but it's really not. What it is this favorite teacher has a way with me. So Jennifer comes over and says, I'm going to do the breathing, then you. But the point is, we start off with these self-management, and then we start to cue it later and later in their day. So the idea there is we treat it like a skill to be learned. You know, we don't treat it like you have to use your coping skill like it's a punishment. Anyway, those are some of the things that we do, and I'll show you now an example. So this is Big Dog. Any of the examples we use, we always get the kids' permission to show their case. So we say to, you know, Teddy here, let's say, Ted, can we use your case? You've done such a good job. And we talk about the shower routine. And he assents. And then his guardian, his parents say, and it's okay too. But the kid has to start off first. If they say, I don't want this, we don't do it. And then we always say, all right, Ted, so we want to use a cool name for you, Teddy. Oh, yeah, right. But he can't, that's not his real name. But no, it's got to be a cool name. Tedster. Nah, it's still too close. Big Dog. All right. So Ted wants to be known as Big Dog. And Big Dog is 21 years old. He was an Eagle Scout, doing very well, ready for college. And then at 18, he had a very severe traumatic brain injury. And part of the area that was damaged was the front part of his brain, which can really affect behavioral challenges. So you have a low threshold for frustration, disinhibited aggression, and very severe episodes, enough to come into a special school. And the area of concern for him was showering and toileting. And there were a bunch of them. This is also another example. When you're dealing with challenging behavior with a kid, you contextualize it. So coming up with a plan to eliminate all aggression all day, all circumstances, like, come on, you know, but coming up with how can I do my shower routine better is a little easier nut to crack. And showering and toileting happen every day, and sometimes more than once. So if I can get a context like that and work on that, I have something to build on, okay? And that's another thing to have in your head. I've got mouthiness, I've got disrespectful behavior, I have meltdowns, my child is 16, how are we gonna, well, what are some contexts that might be a good one to start with? It happens a lot when we're getting ready in the morning. So we could build a getting ready in the morning routine and reinforce that and create a new routine, successful getting ready in the morning. We've eliminated a chunk. So that's the rationale that you're seeing here. So his frontal lobe injury creates a severe problem with executive function. So here's someone who graduated high school, was an Eagle Scout, doing very well, must have had the ability to do all of these things, but after their injury, they become very aggressive. When prompted, when someone interrupts their behavior, they're very impulsive. So in the shower, it looked like grab the soap and squirt it on you. And I know that because I went in there to kind of do a baseline, like, okay, Teddy and a Big Dog. And he would just take the little shower head. Why don't you rinse your hair? And of course, all over me. We did have a staff who was really good with him. And I watched and I was like, what are you doing? How are you doing that? And she goes, I used to work with dementia patients, and you have to lead them through it and give. I was like, yes, you are right, spot on. So a lot of work then became to operationalize what she was doing. But what's going on with Ted is he doesn't have the ability to start the task and to stay focused and get things done in the right sequence. Sequencing is a huge problem with executive dysfunction. When he gets frustrated, it becomes aggression, so he can't regulate, and he takes too long. So now you start prompting him, and that increases his frustration, etc. So what he needed, even though he once had this skill, he was an Eagle Scout, he had to learn to do the showering sequence all over again. And this was Shavana's plan. This is how she did it. So I operationalized the staff who could get him through his showering, and then taught it to all the others. And so turn on the water, make sure it's the right temperature, wet yourself completely, go top to bottom. Okay, what are we going to do, Ted? And he goes, top to bottom. Great. Where do we start? On your head, top to bottom. So this became a very easy cue for him. 3 squirts of shampoo, wash your hair. Why don't we not give him the shampoo? Exactly, yes. So we're preventing a problem. Here you go, 3 squirts, ding, 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 more. Oh, you want 4? 4 this time, but it's usually 3. So we could work flexibly on that. and then all the way through the sequence. And then there was a little point here where every 3 steps he got a Skittle. Okay, every 3 steps a Skittle. It's a small thing. We never wrote it in because after a while the staff forget to do it, which is fine. This just means that at first we jumpstart the plan with lots of rewards and then get it more naturalized. So this was Teddy's plan. And look what's going on here. This is how we do it, right? We add some rewards for completing the daily task. We add this visual and vocal cues. So there's a little thing there, but most of the staff are using it to prompt him. We added some room for flexibility to make it less demanding. And it was a well understood structure for this contextual routine. And that's the solution for Teddy, who did very, very well with it. Here's another example. This is Ariel. What should your name be, Ted? Ariel, but that's your staff. That's my favorite staff. Okay, so he's now Ariel because that's his favorite staff. So he had a very complex brain injury. It involved intrauterine exposure to toxins, the development of abnormal brain structures, polymicrogyria, a little tiny gyri, and then lots of learning challenges and major problems with control of impulses. So transition to school was one of the contexts. He could have aggressive impulses all day long, but transition to school was a context. So again, we're contextualizing the problem. And here's what our staff did. So school transition, they said they noticed him that he would engage in stall tactics. And then when you try to interrupt the stall tactics, he would aggress. So does it sound familiar? Yeah, that's my son too, had this problem. This is, look how long it takes here, right? This is like, 40 school days to analyze the problem. It seems like a long time, but what we're doing during this is we're talking with him about getting to school. And at first he's like, I'm not talking about it. Okay. Now his mom is also hammering him on this too. She's like, you need to start going to school. You're 19. You're never going to grow up. So we're trying to keep everybody calm, and we're trying to get him to agree with us that the nature of the problem is you get yourself distracted. You're using the computer. We should turn the computer off. No, don't turn off. Well, hold on. If you do that, you could get your school day started. You could go through your day. So we're going back and forth with him to reach the point where we have a consensus. That's going to be a difference, by the way, in sometimes what you hear from a behavior analyst in a school. This is more like a psychologist approach, but I'm proud of our staff. We want to collaborate with the kids. So they understand. He knows he has a problem. He knows he can get aggressive, and he feels bad about it. He loves his relationships, and then he does this aggressive thing. Imagine the sadness that he has when he looks at the person who he tried to bite just a few hours ago, So he values his relationships. He has poor self-control, and he can't stay on task. So we're talking to him about that and trying to get to a consensus about what his plan should look like, and he collaborates with us. So his plan is, all right, this is what we noticed. He used the computer until the morning staff arrived, and then getting off the computer is very difficult. One of the things about these behavioral approaches, when you lay them out, everyone goes, gee, I could have done that, I have the same discussion with my plumber. It's sort of like, I think I could have figured that one out. We'll do it next time. Feel free, So there's something about the way the behavior analysts look at it, and they find that one key moment. If we can get him not on the computer and have a clear, consistent morning routine, everything happens in the right order. Okay. And then a reward for getting to school. So this was their thinking. And we thought that the behavioral challenges increase his time on the computer and reduce his time going to school. By the way, I think I showed you before. Look, it was taking him to get to school. What is it? An average of 52 minutes to get up and get to school. No, the school is across the parking lot, by the way. So it's an hour to, I'm doing this, I'm doing that, I'm not focused. So we thought that about, 20 minutes, shower, have a bite to eat, and then head over to school, and 5-minute walk across the parking lot would be about right, So we created an environment where he's likely to succeed. We eliminated the computer. So that was a point of struggle, but we said, I know you like the computer, but what else do you like to do? And these were some other things that he'd like to do. So he has a box that he can get things out of. It comes out in the morning. He does these things instead of computer. Computer's so rich and compelling, but hey, put away your puzzle because we have to get your day started. It's a much easier transition. Create a visual for the morning so he can see the sequence and get positive feedback. Likes his staff, loves his staff relations. So when the staff say, good job, there you go, you're going through your routine. And then computer time once you get to school. And then if you get on time, double prize of donut. So this is what his plan looks like. This is actually the card that we created for him. So you have these little Velcroized steps here. Ready to start your morning routine? Let's put your coloring away. We're going to go downstairs and have breakfast, brush teeth, shower. These are the order that he and his clinician worked out, because breakfast is the favorite part. So why start with the hard thing when you're having a hard time getting started? But once the momentum established, all done, all done, all done. Great job. Get a check mark. Bring your check mark to your teacher, and that means I got my morning routine done. And then if I arrive on time, I get the donut. So we'd set time goals with him. Now, this is how long it took. Okay, so a year, right? So we got to, a lot of improvement at first, and then big improvement in 6 months. But we really hit our goal around 3/4 of a year, somewhere in Q3. And then he got even better. He started racing to school. So I'm showing you this because he had a complex brain problem. He's 19 years old, and this problem's been going on for a long time. We're not going to unravel this thing with one big donut, but slow steps over time will get there. Now, he's no longer a problem with getting to school. It's just a non-issue, and he runs through his routine with just verbal prompts: time to do this, time to do that, blah, 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 blah. And that's the way it really looks with chronic neurobehavioral problems, is that you have to get ready for a life-changing skill development, getting up in the morning and following a routine, and you have to take it that way. And again, we have this too. You and I could all stand to, I don't know, go to the gym more and walk your 10,000 steps or something. I had a Fitbit. I have it on now. Look at my app. I didn't do my walk this morning. Still at 2,500, so I still have time. But here's the thing: is when I first got her, you're like 4,000 steps. Yeah, I thought I was really huffing it today. What am I getting? Oh, 3,200. I sat around all day that long. And that feedback, after a while, you go the next week, it's like, wow, 6,000. Yeah, doing great. And it took me about 8 weeks to start bumping into 10. And I wanted to do it, right? So it's the same thing. It's hard to establish new habits and change behavior. And this is more of what it really looks like. So you got to have that in your head when you come up with behavioral strategies for your kids, that this is not tomorrow's solution. It's 3 weeks from now, it's a month from now, it's 6 months from now to really get to where we want to be. But I have a good plan, and I'm going to persist with it. All right, so here you hear again, our strategy is to work on contexts where the problems occur. You can always build a new context, a structured approach, a very, it's a positive behavior that's an alternative. So this is now all the rewards are for getting to school. All the rewards are each step. It's more and more staff. I'm proud of you. And we're not eliminating a problem behavior. We're building a new one. Yeah, that's usually our attitude. Notice that they modified the environment. They added the visual. They eliminated something that was causing trouble. The computer access in the morning, they gave him something less exciting, but still valuable. They added rewards, copious praise, and then they took the long-term approach. The small gains become big wins later. Small gains become big wins. And everyone was patient, just saw this as a slow accumulation. And then in this case, and this is valuable too, if you can find some way to operationalize the challenge that you're working on. How much time does it take to get ready in the morning? How many outbursts did I have during the get ready for the morning? And just track those, because you see change in slow accumulations, not the perfect elimination. So that's what you saw going on there. This is Wonder Boy, right? Wonder Boy was, Teddy, I want to share your beautiful improvements with all sorts of people who are psychologists and teachers, but we got to come up with a cool name. What do you think? And he said, Wonder Boy. So this is Wonder Boy. We love doing this with the kids. They're proud of their successes. They want to share it. So Wonder Boy's 12 years old. Now he has autism and not a brain injury, but he's very, very verbal. He has a high verbal intelligence, but very, very poor ability to modulate how he uses those words. And he gets this diagnosis of oppositional defiant disorder, which it's not really clear if it's a real disorder, but it's clearly describing a behavioral pattern of refusal to follow adult expectations and all. And he had a trauma history too. And the American Academy on Child and Adolescent Psychiatry does say that you avoid that diagnosis in people where there are other mitigating factors that could explain it. So I've got autism, so I'm sort of rigid and focused, and I've been abused. I don't think the ODD works, but nonetheless, there it is in there. But it just means it describes someone who's been a challenge to people. And the challenges that we see when he entered our school was banging his head very forcefully, requiring people to put their hands on him. And you don't want to be doing this with kids, but to protect them. And then aggression and property destruction, disrobing, and then provocative sexualized touch. So he would go up to a teacher and talk and touch them in a way during one of these outbursts. But because of his high verbal abilities, some of his educators thought that, he's just playing us. We got into the blame the kid thing. So this took a lot of education for us with staff who are used to doing this, right? So the pre-intervention components were, again, we're going to meet with Wonder Boy and talk to him about what we're seeing. We noticed that sometimes you get so frustrated, you tip over your desk. What are you thinking? I don't want to talk about it. Okay, no problem. And then right after an episode, wow, you got really upset. I did get upset. These are the sort of things that get you so upset that you want to tip over your desk. So after a while, we were able to openly talk to him about this. And that's a huge, huge strategy for parents to develop a plan with your child, not impose it on them, to talk to them about, we want to work on this. And I've just seen it so often. You have to get over the distress about and the shame of talking about what the child knows is going on. And this becomes a great moment because the clinician becomes my helper all of a sudden, and the parent can become my helper if we can get into an open dialogue about this. But it takes time. No child's ready for that at first. But this is a great parenting because, you can be permissive or you can be an authoritarian. Don't do that. You're punished. Or you could be, oh gosh, he's just going to do what he wants. Neither of those are very good, but somewhere, not in the middle, a whole different style of parenting to be the authority on life, the one who's going to help you be a success. That's what we all want to be as parents. So being the authority on how to help you with your behavior, let's work on it together, could be a very, very, very therapeutic experience for you and your child. That's how we do it. So here's just a little formulation. Have you seen these before? ABCs. A lot of people who get consultation around challenge behavior. This is everybody leads with this. Okay, there's what triggers the problem. School demands. What happens? He gets aggressive or property destruction, and then what's the consequence? Well, the work's done. You can't do the work when the child's fighting with you. So in other words, I avoided my school demand. So it's a pretty easy formulation based on objective observations and other tests that we do. But what should Wonder Boy be doing with school demands? I don't want to do my work. What should he be doing? Oh, easy. He should just do the work. But no. What should he be doing when he doesn't want to do the work? Yes.
Give them the opportunity to do it later.
Yeah, good. Yeah. Negotiate. I don't want to do it right now. I need a break. So use your words. So great. Yeah. And maybe negotiate doing it later. Or maybe we say, okay, so you need a few more minutes on break and then we can come back later. So that'd be a preventative strategy. But I would like to teach him also to say, I need a break right now. So he has a way to escape work that has nothing to do with aggression or property destruction. So that's the beginning of it. Or can I do it later? Yeah, we could do it later. I use my words, I escape my work. But then this creates a problem. When do I ever get my work done? So that's obvious. So then the next thing that he needs to do is we had him set up a schedule of his work. So I'm not doing the work, okay, but I'm talking about doing the work. That's always a good way to get someone to do something. Well, which one do you want to do first? I hate the math. I'm just going to do my reading. Good. Okay, you got the reading. What else do you want to do? Can I take a break now? No, you have to do 2 work and then a break. I'll do the math after the read. Okay, and he writes out a schedule, and this is his structure. And then, do we want to get started yet? Now he can say, no, I need a break. Okay, but once you get your work done, you get tokens that are cashed in for a special reward that he's selecting in advance. So now we have a way for him to say, my motivation to work is shot. I just need a break. And we can say, you ready to get back? Because remember, we're working on tokens. And he comes back to work. It's still too hard. Do you need some help? Let me help you with this one. You've done so good. I'll finish the last problem. Okay, you just have to sign your name. All done. Good. Here's your token. So we have a way for him to get out of the work when the motivation is low, to join the work when the motivation is high. And the motivation is high because there are these select rewards that are available. And that's the function of this plan. This is just, my intern, Catherine, presented this at a conference. And basically, she's outlining everything that we talked about, that we had to do things to engage him and creating his own plan. And the components of the process are what I've been saying. We develop the plan together. All right. We teach these, we talk about it as an important skill for him to develop. We talk about rewards. We talk about the positive behaviors, and then we talk about the negative behaviors, the things we're working on improving. That's almost the sequence. So he sort of worked into it. I want to earn my rewards. And then, okay, so we're trying to now, when you're frustrated, instead of tipping over the table. So we do all sorts of moves like that. These are Wonder Boy's data. So when he first arrived in the school, look at that, a whole long time there, 45 days. You're like, that's a lot of time, but we're building our relationship with him. We're trying to get him to open up about awareness of this problem. And we're defining behavioral goals together, and he's defining rewards, and he's building relationships with his teachers, and things are getting worse. But we know that the process of engaging him is the first step. And then we get into the intervention, and you can see a large drop off in the problem behaviors. And this is what behavioral change looks like. You can see there are ups and downs. So I have some days that are just not going well. And then what you also see, if you look carefully at it, look at how long between behavioral outbursts is happening. So in other words, it's 3 days, and then I had an, and then 6 days, and I had an outburst, and then, 8 days, and I had an outburst. So behavior change with your kids will look like a slow accumulation, not a sudden drop off. This was a sudden drop off, as you see, but it never eliminated anything. And now here we are. The other thing you see is there's this chance that that last data point there is the intervention is so good, I guess, that he wants to get back on track and start earning his rewards again. So in other words, even my meltdowns are getting, I think, shorter. That would be our next anticipation. I've been talking a lot. Does anybody want any questions? Because I could keep talking if you want. Yes.
Quick question. Closely, can you coordinate between the early imaging that's done on children to specific neurobehavioral issues?
Yeah. So the only thing that you can do in the research that I read and all this stuff, you can look at the long-term trajectory of a particular stroke or particular type of injury. You can see the immediate problems, particularly a frontal lobe, orbitofrontal injury. So this real part of the brain that when it's injured, the person is very severely disinhibited, and they can become aggressive and poor focus and everything. So you can see those problems right after the injury. But then the long-term courses, it's sort of like how many are going to develop it. In children with brain injury, about 50%. So I don't know that there's like a lesion specific. There's a course of risk of developing a neurobehavioral problem at some point following those sorts of injuries. And a good percentage of injuries are later emergent in children. So they come out at 3 years old, and there's some developmental problems, and there's a lot of rehab or habilitative services wrapped around. People are pretty tolerant. They view everything as a developmental delay. But then there's a point where something in the environment now is a poor match for the child. Frustrations build up and behavioral problems begin to emerge. So that's about 50% of kids have late emerging neurobehavioral problems.
So there's really no way to sort of predictably try to address some of these issues or do some of this conditioning behavior beforehand.
I would say there is. I don't know the study, but I would say that if you could educate families and try to build structures, try to see the small, we only see the problems when they're, quote, clinically significant. Right. So if families could be educated possibly about the risk for developing these problems and try to address them early, that might be. I mean, I'm just thinking out loud. But I'm not aware of a predictive like this would. Another thing is the managing the family stress has been shown to lower the risk for the development of a neurobehavioral problem after a brain injury in a child. So family stressors are are hard. It's just hard to balance all these things. So family stress management may have a preventative value.
And the reason I ask is because there are a lot of young children with this disease and they're able to see the brain injuries very early, but you don't know necessarily what that's going to entail for neurobehavioral issues later on.
Yes, I would agree. I'm not aware of being able to predict it. I would also say this then. I would say get neuropsychological testing. Don't rely on your district. Get a qualified neuropsychologist. Maybe the district can be provoked to pay for it. Maybe the neurologist would write a medically necessary authorization for it, maybe, but get the neuropsych testing. That's going to give you a finer understanding of neuropsychological problems like processing speed. And then you could put accommodations into place that might have a preventative benefit. The other thing is with early neuropsych testing and then repeated neuropsych testing, a good psychologist would try to repeat same tests or tests that measure the same phenomena, and then a trajectory can be established. So it would be super valuable. That may have a thoughtful potential preventative.
Thank you.
Well, that was easy. Are you a provider?
No, my daughter is a teen with MSMDS, and we've always had a lot of discussion about how the early white matter injuries that we saw in her would affect her. And, you know, like you were reflecting on some of your studies, is this behavior related to her injury, or is it just related to personality or general behavioral things?
Yeah.
And it's very hard to know, especially
Yes.
when there's subtle behaviors.
Yeah, yeah, and you know, I don't want to land on it's all neurobehavioral disorder when these problems emerge, because you know, kids have snarky things, and they, you know, my wife took Michael in when he was 6, and she said he mouths off at me, he won't clean his bedroom, it's like he's just tuning me out. And he said, little kids have little problems, big kids have big problems, be happy for the little ones. And he left. So what kind of advice was that? And I said, I think he was saying it's normal. This happens. Let's just get used to it. Let's try to work it through it, you know? So there's going to be some of those too, because kids have their challenges and problems. But I think if you realize the risk for this being a potential, you know, behavior disorder over time, to, you know, maybe work on it more carefully and not just assume like with Michael, it's just going to get better in time. We've got enough things to worry about or something, but to really take it on. Did you approach it in such a way, like thinking this, we want to make sure this doesn't blossom into something else?
Well, we had early neuropsych evaluations done, and that was very helpful to look at those and to establish sort of where she was at. But then I think, you know, as she get older, we were just alert for certain behaviors and trying to understand and intervening very early if we saw something that was an issue. A lot of them have resolved themselves.
Yeah.
And now she's getting ready to drive. So,
Oh,
yeah.
now you need the stress management. Yeah. That's wonderful though. And I think you're saying, you know, be alert for it and try to resolve the problem, really work with a neuropsychologist.
Yeah. Oh, but we had a lot of questions, obviously, when we saw initial imaging and things, you know, how this is going to affect her, what things should we be aware of?
Yes.
Before she had even developed those skills or was on track to develop certain skills, we were looking for those things because we had seen the injury very young in her.
Well, that's great advice for everybody. So I would say that, you know, if I'm not a testing neuropsychologist, but I sometimes partner. And if a parent said that question to me, I could possibly answer it. Like say, well, you might want to be thinking about this. And I would give them counsel in the direction that we're talking about, you know, watching these things and don't let them emerge. And I'd probably give them, you know, parenting strategies to coach through the problem or teaching alternatives.
Right.
Yeah. So this is
I believe it's another question.
yeah. Oh, I'm sorry. Go right ahead.
No, it's fine, it's fine. I just wanted to say that because our kids' brains are affected and ever changing, that the behaviors are also,
Yes.
oh, thank you. That the behaviors are also ever changing. And so what may work now may not work tomorrow. What behaviors we have now may not be the behaviors tomorrow. And I think that as parents, at least for myself and maybe my husband, when we kind of look at the behaviors as a part of the condition and not a typical child behavior, we become that helper
Yes,
we have that helper mentality where it's like, this is something that they're struggling with, they can't control it. This isn't my kid being a typical kid.
yes.
So I think that kind of helps sometimes put things in perspective when you're trying to keep your sanity because of all the behaviors and all that stuff, as opposed to losing your breath.
Thank you. That's a beautiful wisdom for everybody. I would say that I try to convey something similar to our staff, and that's what I get at with try to understand the neurology and see this as a struggle and challenge. So great advice for families.
May I ask a question?
I had a couple questions. One, we had neuropsych testing done, but they didn't like have any, like they didn't see any issues, and now we've seen like an increase in behavior issues dramatically. Would you just suggest that we get like a new neuropsych testing? It's just, the problem is he doesn't have behaviors for anybody else.
Yeah,
Everybody else thinks he's perfect.
yeah.
So he waits till he gets home and
Well,
those things.
they're always tied to the environment, and sometimes they generalize across environments. So that's not, that doesn't mean you did it. That doesn't mean that you're doing something wrong. It could mean that there's a form of behavior that happens at home that's hard to not reward adventitiously. You can't dance around it easily. So we don't know what it is, but that's what it means. It doesn't mean the family's inadequate. Just got to get that one in your head.
He's a people pleaser,
He's a people pleaser.
so he won't have that for anybody else.
Yeah.
But for us, he doesn't care.
Yeah.
We're gonna love him anyway, but
Yes.
so I don't know how to like get a neuropsych doctor to like help us with him when they don't see his behaviors, I guess.
Yeah, they don't. Okay, so for that, maybe there's how old is your son?
Yeah, my son, he's 6.
6. Okay. Is the district aware, the school district that this is going on? And-
Yes, the school that he goes to is very nice. They're doing their best, but he's the most medically complex kid that they've ever had.
Yes.
And so they're doing a great job, but like I said, he doesn't have the behaviors for them at
Yeah.
all. They don't believe us that he has behaviors.
So for me, I can do clinical interviewing and I can gain some understanding of behaviors that I don't see. I can use forms and evaluations and checklists that can give me another picture of it. And then sometimes I can come out to a home and do an observation to try to get a formulation. That's what we're looking for. But the clinical interview and the use of certain, forms that you complete and take notes as things are happening and record events can allow us to get a formulation of what we think is going on. We're trying to identify the environmental circumstances that are likely to evoke the problem and maybe what follows after that might be a source of reward through, again, nobody's intention, and then try to come up with a plan that could teach other ways to get those same rewards or to eliminate some of the triggering events in the environment or to identify with you a good context where, gee, if there was just improvement in this area, that would make life a little bit easier. So those would be the sort of things that could be done through an office visit, but a direct observation would be great. So where do you get that? Well, one would be if your district would agree to a home behavioral consult, and that just depends on the generosity of the school district. Unfortunately, some of them will say, well, that's a home problem, not a school. Others realize the whole child is affected. I'll get better school days if there's better home days. Others realize it as, well, that's home now, but it's going to be at school next year or 2 years from now. So let's get a handle on it. So it might be good if you have a good relationship with the special education department to see if you could get some home consult. But there you're going to have to be careful. Okay, I do this with every referral. Sometimes it doesn't click. So you have someone who comes in, I don't know, maybe she's 22 years old. She just got her BCBA and she's going to tell you how to be a parent. So that would be all wrong. But maybe she's 22 years old and she's totally humble and realizes that she's here to help and she's going to try to apply what she learned to help you take little steps forward. So I think the first thing is, so if you get someone who's going to come in and give you a consult, it's got to match with your values. They got to be approaching you compassionately. They have to really understand that you're the expert of your child and they're here to help you, give you a few little tips and strategies, but you're the expert. So why don't we talk I'm going to give my email and then also we can talk after and we can maybe go over some more of this.
That would be perfect.
Okay.
I did have one other
Yes.
quick question, sorry. We also have a 4-year-old and how do you do you have any suggestions on how? She's a terror. And she just does what he does when he's throwing a fit,
Now,
because he can't control it,
Yeah.
he has issues, she can control it. If she would just try, but she refuses to. You just apply the same techniques to the child who is neurotypical.
you could.
It's
you
just like
could.
learned behavior. He
But-
threw a brick, so I'm
Yeah.
gonna throw a brick. Like,
So let's say we get Big Brother, who I like to be like, to get on a plan and he's earning little rewards. She could be on one too, because she doesn't need it for the neuro-driven reasons, but she needs it for the I want to be like my brother reasons. So she needs it for her developmental reasons. And it can be fun to be earning rewards for my activities around the home. So I think it's possible that if he's on a plan, she gets on a plan very similar. That's how I might handle it. But let's talk after, okay? And we can go into more details. But that's I want to just finish up with one more. I think I have two more, but this case is same plan as Wonder Boy. This is Tommy. No creativity there. Tommy, come on, man. Snoopy, you got a better name, but well, it was Tommy. But this just shows you that it takes a while with some kids, and ups and downs before we get to that long strand down at the end. So 121 school days is a long period of time. That's half a year to get to this point where we're really getting at. But we knew the plan was solid and we knew there was good reason to get published. So the editors liked it. And that was, so these two things that we get for principals is that change needs to take time. It's about, learning new habits, working collaboratively first. You set up the plan with the child. And then we're sort of like, you're the expert in life. This is the book that I wanted to recommend. So the Kasdan's book here is all about this kind of points and tokens and setting up contracts with your kids about this is how you earn it and let's work on this. So this will go into some good detail, and it's meant to be like you can read it and walk it through, apply it yourself. I think at the time the book came out, probably the same, there were downloadables with it. I think one year they sold it with a CD or something that has the forms, but you should be able to get all the things you need to consider applying these sorts of things. One last example, Frank, this is a severe case. So his brain injury happened somewhere in the first month of his life. And he also had a trauma history or just very severe neglect and was withered and needed to be removed from the home. And when he entered into our program, his severe problems were making suicidal gestures and threats and property destructions. And he had multiple trips to the ER because of these things. Again, I just wanted to show you that a very complex case can be unraveled using similar principles. We did know that he loves his caregivers. He liked to be, he liked people to be proud of him. We noticed that a lot of the behavioral problems happened when staff were too busy to be with him. So this is my way of getting you to pay attention to me. He had very poor ability to start tasks. He could stay on them, but he would give up too easily. So he needed like a lot of support to get things done. And then his challenging behaviors, again, occurred during unstructured time, and they always resulted in staff, doing things to help calm him down. But what else should he be doing? And we said, well, we talked to him about doing chores around the house and get 3 points. I did the chore, get a point. I was safe, get a point. I didn't break anything, get a point. So it was a similar plan with points and prizes, but for doing chores around the home. And why chores? Because chores require staff to help him. So I don't know if this is the plan for staff, spend more time with Tommy, or it's the plan for Tommy. But Tommy could then be proud of himself. I did the sweeping. What else do you want me to do? So he had a great way to always engage staff with him, but also learning chores. So Tommy's improvements are illustrated here, his aggression and property destruction. These triangles are transports to the emergency room. The phase line there where we added trazodone was just because we noticed a lot of them occurring at night now. So instead of all day long, we're getting them at sleep onset. And so the idea was, well, maybe he just can't fall asleep easily, and this might help him. So that was and the follow-up there are, 3 months of still at super low rates. So there's Tommy, Frank, I'm sorry, his name Frank. He said, we want a cool name, Frank. I don't know where it came from. And his mom said, please use this picture because I'm proud of him. And one day I was walking across the park and I said, Dr. Jet, did you see all my points? I said, no, I didn't, because you have to come and see them. I got lots of points last night. So I'm like, oh man, I gotta go. But what are we gonna do? He's proud. So I gotta run over, change my meeting, go over there. He walked me through it. I said, can I take your picture? So there he is. I like my points plan. It helps me get stuff done. I get to earn things. His mom said, I never thought he'd do chores before. And then it allowed us to now have him go home first from 1 hours to overnights. And his mom would do the chores plan with him, but they had a nice way now of mom and son being, I guess, successful and all. But that's Frank, proud of his points plan. And so this is what we heard, right? I'll just skip to this part, actually. Quick review of the philosophy, and I think that's what I'd love you to take away. So we want to increase skills that replace the problem. We want to teach the child and avoid blaming. Make the environment better for the child to succeed by adding structures, add lots of rewards, hard on the problem, easy on the child. You're the solution, no blame, a good kid. So thank you so much for this time.
Yeah, but I think there's a lot of questions.
We have a lot of questions.
I
Yeah,
think
we
there's
have
a
a
lot.
couple, we have a couple
Okay.
online that we're trying to. So the first question, microphone's not open. First question is from Adam Caruso. It says, what about newborn or very young children who undergo extensive surgeries and procedures and are introduced to very powerful sedatives, narcotics, and anesthesia? Could exposure to those interventions result in behavioral and developmental issues?
Yeah. So I think that's a question for the prescribers or for the pediatrician, because we'd have to know what and you know, I would imagine that there could be risks with things, but there could be ways that risks are mitigated. So I would say that I wouldn't be the right one to answer that question. But if you're worried about that, then I would bring it up with the pediatrician and go over the history, but then also what can I do to accelerate development given maybe injuries that have happened or given delays that might be provoked because of necessary medical treatments. There are kids who have complete hemispherectomies because of seizures at a very early age, and they go on. Some of them have lasting developmental and cognitive problems, but many of them don't. And they develop a lot of splinter skills, meaning there are areas where I'm very solid and very skilled at and very typical, and then there are areas where I struggle. So what you described right there is not a guarantee that your child will not develop and be successful. But I would ask those specific questions to the pediatrician.
As a follow-up question, he did ask, as far as brain development goes, could those exposures to those early medical interventions intensify his son's susceptibility to what this genetic condition already makes him prone to do?
Oh my gosh. So I'm a newbie to all of that. I can only speak hopefully about resilience. And I'll just say that I've worked with lots of brain injured children who make leaps of progress. And I've never dealt with brain injured children who are filled with despair. They're very hopeful, they're very proud, they have goals that they want to achieve in life, and they're good contributors. You feel good knowing them. So I guess I would say, talk to your doctor about these questions and be hopeful, because I've seen lots of wonderful people, children who have these problems, and they're beautiful people. Are we done?
No, I have a question.
Okay.
First, I just want to say thank you. This is a wonderful presentation and very much needed in this community. Our son Raceland is 7. He's nonverbal, was quite developmentally delayed after a 26-month hospital stay. And at the brilliant age of 7, he just figured out how to say no. So we are running into some of these behavioral issues, and the challenge that we're having is that he has one-on-one nursing care. Both parents work full-time. Obviously are part of this organization. We're just incredibly busy. And then he's going to school part of a day in a regular classroom and part in a special needs classroom. So as we're running into these behavioral challenges, we're seeing he's doing a lot of head banging, a lot of physical physically dangerous things, right? So we have, if I'm with him, I will physically stop him because knowing his disease process and that he's at a very high risk of brain injury with a vascular stress, I just physically stop him from doing it and reroute him. But then we have nursing who's like, I don't want to touch him. And so he just continues to do it until they can, reroute him some other way. And then we have, the school saying we can't really touch him. So I guess my question is, do you have a resource, because I'm very much of that same mindset of the video in the first presentation, that like there's so much to do and I just can't do it all. And this information is amazing. And how do I implement it across the board for someone who's with the child all the time?
Yeah, that's a challenge that we face all the time in our school, because we'll have, 6 teachers in and out of the classroom, 4 that are there, 2 relief that come in periodically, and then a residence that has 12 staff. So how do we do it? When we do have a plan that we know is going to work, and you've got that question too, is we can, and you could work with a clinician to just operationalize it into steps. And then we observe the person and give them feedback, observe the person, give them feedback. I know it is a ton of work, but here's what it is. It's a skill that you're going to use going forward too. This kind of like, let me teach you the plan in this operationalized way, but you need someone to help you get started on that, because there's a technical skill set for that. But I guess my point is that there are ways to get people consistent across settings, okay? And behavioral clinicians should know about them. That's the first thing. But the other one is, we're at the beginning stage of, wait, how do we understand what's triggering this problem? And that's a big one. So this kind of like ABC chart that you saw up there, you can go online and say behavioral ABC data recording chart or something. And what you want to do is you want to say, well, what's my B? What's my behavior that I'm going to track? Not everything. It's something very specific. If you said misbehavior, well, then I don't know what it is, and outbursts. Well, what's that? But if you said the head banging, and then if you started to notice that preceding the head banging, you would do something like this and rock. You're like, okay, so rocking is my precursor, and then head banging. Now I want to track what happened just before. Okay, and if you got 10 data recordings, okay, you can look at that and you can sometimes say, I think I know something about triggering events. How did I handle it after? Well, a percentage of the time people came in to rock them because that's what nurses do. And then another percentage of the time people waited it out. And what am I seeing here? Well, sometimes people provide him with a great deal of tender consolation when that occurs. That for my son is like a big hug. That's like a big reward. Doesn't mean don't do it, because you have to. I see what you're saying. So this trigger, and what could I do to teach him under those conditions to ask for what he needs, or what could I do to provide what he needs in the middle, at the precursor, before it becomes. These are just sketches of what you would do. They're concepts, but I think you could find a behavioral clinician who might help you assess it at home. That would be the thing. Yeah.
Great, thank you so much.
Yeah. It's always a milestone when a little kid first learns to say no. Sorry.
That's right. It's really cute, actually. Yeah.
I'm in person here, so good boy. We just have to get a little bit under control. All righty. All right, I'll be hanging out. So thank you so much for inviting me.